presentation. Great. Okay. Beautiful. There's now 11 people. All right. Welcome, everyone. We're just waiting for another minute to get more people in here. Participants, great. Okay. We are now live on our social media channels as well. My name is Maria. I'm the Executive Director of the Gatehouse, and welcome. This presentation speaks to me in a variety of different ways. So I'm really excited to hear from Kaitlyn, who is the Program and Outreach Coordinator at Sheena's Place. Today, if you haven't seen any of the other presentations, they are available on our YouTube channels, our Facebook pages there at any time for you to see. And we are live now. So we welcome any questions that you may have or comments. If you're watching this on Twitter or Facebook, I'll be monitoring those comments for any questions you might have for Kaitlyn. And as well, if anyone has questions or comments, we have 25 participants in the session at this time and slowly increasing. You can definitely post your comments or questions in the chat feature of Zoom. More than welcome to. So without further ado, I'm going to turn it over to Kaitlyn Axelrod from Sheena's Place. She again is the Program and Outreach Coordinator there. Thanks so much, Kaitlyn, for being here today.
Thanks, Maria. Hi, everyone. It's really great to be here. I am just going to share my screen and then I'll get started. And if at any point anyone is having trouble seeing anything, just let Maria know and Maria will pass along the message to me. Okay, so my name is Kaitlyn. I use she, her pronouns, and I'm a social worker and, as Maria said, the Program and Outreach Coordinator at Sheena's Place. Before I get started, I just want to acknowledge that Toronto is located within the Dish with One Spoon territory, a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. As a non-Indigenous person, acknowledging these traditional territories is a reminder to appreciate and recognize not only the physical land, but also the history of those who were living here before European settlers. Indigenous peoples of many nations have lived on Turtle Island for the last 15,000 years and continue to live here. To learn more, you can read the Indigenous Ally Toolkit, which is a resource I highly recommend, created by the Montreal Indigenous Community Network, and I can share a link to that as well for those who are here. I will just do that very quickly. Oh, actually, I don't know if I can do that. So Maria, I'm going to send it to you. Okay. Awesome. So again, I'm really happy to be here. I will do my best to be succinct. I know this is not a ton of time we have, and I hope to leave time for questions at the end. Before I get started, I just want to acknowledge as well that some of the content I discuss may bring up difficult emotions. You know, everyone has their own relationship with food and their bodies, and we know that a lot of people do have trauma histories as well. And so please do what you need to do to take care of yourself. I will not be offended in the slightest if you have to take a break or leave. The most important thing is to take care of yourself. Okay, so briefly what I will be talking about today, I'll start by talking about Sheena's Place. I'll talk about eating disorders, bust some common myths. I will make the link to childhood sexual abuse, and then I will provide some information about providing support, as well as community referrals and resources. I am happy to share that information at the end as well in an email. Okay, so Sheena's Place. We are a community mental health charity. We support people affected by eating disorders. And we do so by offering a wide range of groups. So we don't do any individual counseling or therapy or treatment. We provide exclusively group support. We have different types of groups. These include support groups, skill building groups, body image groups, expressive arts groups, and nutrition groups, as well as educational webinars. Our programs are all free of charge and based on self-referral, so no one needs a diagnosis or a referral to register. Our only criteria is that a person must be at least 17 years of age and living in Ontario in order to register. And I'll provide some more information about registration at the end. As you can see in these photos, we are located in a very homey, non-clinical environment in this very old house. Unfortunately, we are not really using the space right now, and all of our groups and programs are online because of the pandemic. Okay. So I'm going to talk a bit about eating disorders. Eating disorders, broadly speaking, are classified as a type of mental illness in which a person has a negative relationship with food and the body that is harmful to both physical and mental health. Like all mental health challenges, eating disorders occur on a spectrum. So as you can see here, we have some symptoms, what we would call disordered eating in the middle, and then a diagnosis on the right-hand side. We all fall somewhere along this spectrum, and this can change over time depending on context. So I'll briefly talk about 3 more common diagnoses. I won't get into the details because there are quite a few. But the most common eating disorder diagnosis is binge eating disorder. This involves engaging in episodes of binge eating, which means eating an objectively large amount of food in a discrete amount of time and feeling a loss of control while doing so. So it's really this loss of control that defines a binge eating episode. It's not, eating seconds or thirds of your favorite meal or eating past the point of fullness. It's really this loss of control. People with binge eating disorder do not engage in purging or compensatory behaviors, but dieting is very common. Bulimia nervosa is a diagnosis that's characterized by cycles of binging and purging. So purging meaning an attempt to compensate for the binge through different means like self-induced vomiting, excessive exercise, diuretic or laxative misuse, insulin misuse for people with diabetes, and fasting. And then the third that you may have heard of is anorexia nervosa, which involves an intense obsession with restricting and controlling one's food intake, accompanied by a severe fear of weight gain. Again, as I said, there are many other diagnoses. Unfortunately, I don't have time to go into all of those, but the information is available in resources I will direct you to at the end. Something I do want to emphasize is that a diagnosis, someone does not need a diagnosis to be deserving of treatment and support. So many people are in this kind of middle section of disordered eating and are still really struggling and still really need treatment and support in order to get better. And unfortunately, there are very strict eligibility criteria for being accepted to publicly funded treatment programs due to a lack of resources and some myths around eating disorders. So unfortunately, it is very hard to get affordable treatment. When it comes to the prevalence of eating disorders, unfortunately, they are very common. So close to 1 million people in Canada meet the diagnostic criteria for an eating disorder, and many more people live with symptoms. So we don't actually have a great understanding of how many people live with symptoms because a lot of symptoms are normalized in our society and because our data collection is not fantastic. When it comes to severity as well, we know that eating disorders have the second highest mortality rate of all mental illnesses. This is second to opioid addiction. So it's quite high. The leading causes of death include suicide and cardiovascular failure due to caloric restriction, the use of diet pills and laxatives, and self-induced vomiting. So what I really want to emphasize is that mortality and health consequences are not dependent on weight. Professionals used to think that if a person, the lower a person's weight, the more severe their eating disorder was, but we know that that's not true. So on to other myths about eating disorders. The first that I want to cover is around how they develop. So this idea that eating disorders are a choice. In reality, like all mental illnesses, eating disorders develop as a result of many different biological, psychological, and social and cultural factors. So just like no one chooses to have depression or schizophrenia, no one chooses to have an eating disorder, and support is usually required to get better. Most people with eating disorders also experience additional mental health challenges. This is often depression, anxiety, obsessive compulsive disorder, substance use, and PTSD or experiences of trauma. The next myth that I want to discuss quickly is that eating disorders are exclusively about food and weight. In reality, eating disorders serve many different functions, or the symptoms do. So I have some examples listed here. I don't have time to talk about all of them, but I will in a few minutes talk about a few of these that are specifically connected to childhood sexual abuse. And I'm happy to answer more questions about these at the end. Coping with negative emotions, maintaining control, those are two of the most common ones, but this list is of course not exhaustive. All right, the next myth that I want to address is who is affected by eating disorders. So there is the common myth that eating disorders primarily affect young, thin, white, affluent women or adolescents. This is not true. So eating disorders do not discriminate. They affect people of all ages, races, and ethnicities, genders, sexual orientations, income levels, abilities, and body shapes and sizes. In fact, men actually make up between 1/3 and 1/4 of people diagnosed with an eating disorder, and subclinical symptoms are around equal between men and women. So the difference is not huge there. In addition, LGBTQ2S folks are at a much higher risk of developing an eating disorder than heterosexual cisgendered individuals, particularly folks who are trans or non-binary. People who experience food insecurity are also much more likely to develop an eating disorder than people who have stable access to food. And when we talk about race and ethnicity, there's unfortunately a huge lack of data in this area, as most studies are conducted with white women. However, we do know that people of color are just as likely, if not more likely, than white people to develop an eating disorder, yet are much less likely to access treatment and support due to financial barriers, a lack of recognition or diagnosis on the part of health practitioners, and a lack of culturally relevant eating disorder treatment and support services. Lastly, in terms of body shape and size, as I mentioned earlier, this does not impact the severity of a person's eating disorder, and you really cannot tell what type of eating disorder someone has based on their physical appearance. So people of all shapes and sizes can experience all the different symptoms, and so it's really important that we don't make assumptions about a person based on their size. Okay, I know I flew through that pretty quickly, but again, happy to answer more questions at the end. So I'm going to talk now a bit about the link between childhood sexual abuse and eating disorders. So we know that based on research, childhood sexual abuse is a risk factor for the development of eating disorders, especially binging and purging behaviors. So this could include diagnoses like bulimia nervosa and binge eating disorder. It also, again, could include subclinical symptoms. People who experience childhood sexual abuse are more likely to engage in binging and purging than those who do not have a history of childhood sexual abuse. And we know that about 30% of people with eating disorders have experienced childhood sexual abuse, which is higher than the general population. So there are some possible theories or reasons. Of course, it's going to be different for everyone that explains this connection. People are complicated. There's a lot going on, and we can't reduce it to one single cause. However, some of the probable pathways that this could occur, well, there are a few to start, and I'll review some of those. So the first kind of links to self-esteem, self-worth, and body image. We know, of course, that children and youth are in the process of developing their identities, who they are, their sense of self, and their core beliefs. So childhood sexual abuse can, of course, seriously impact a person's sense of self and worth and their body image. Experiencing low self-esteem and body image dissatisfaction is then one of the most robust risk factors for the development of an eating disorder. So that's one pathway. We also know that sexual abuse can lead to dissociation from the body, and this can manifest as experiencing body shame, self-hatred, and the urge to self-harm. And eating disorder symptoms can be used as a way to cope with feelings of shame and as a way to engage in self-harm. Related to that is coping with emotions. So, of course, people who experience abuse need ways of coping with intense emotions. And often folks will turn to substance use, self-harm, and eating behaviors in order to deal with those difficult or negative emotions. Again, this is most often binging and purging, but not exclusively. We know that binging and purging can temporarily reduce anxiety or negative emotions for a lot of people. And it can also numb emotions. So many people report dissociating or feeling numb after engaging in an eating disorder behavior like binge eating. And similarly, restriction can also result in like a numbing or like a distancing from feeling emotions. And lastly, coping with a lack of control. So many survivors understandably feel a lack of control after abuse, and eating disorder behaviors may serve as a way to feel in control. So this could be through restricting food intake, through exercising, through purging. And another connection in this realm is this idea that, thinness is seen as a beauty standard or a beauty ideal in Western culture. And for some people, weight gain weight gain through binge eating can be seen as a protective mechanism to prevent further victimization. Again, this is of course not relevant to everyone, but if you are interested in learning more about that connection, the book Hunger by Roxane Gay provides a really powerful example of this connection between body image, control, and eating disorder behaviors. Related to that, it's important to know that weight loss and weight gain can be especially triggering for survivors, as people may associate a specific weight with their abuse or the time that they were abused. Another important consideration is just around, of course, the limitation of the research that exists. Most of this research has been conducted with women, most likely primarily white women, and so we can't necessarily generalize that to everyone, but based on what we know about eating disorders and who they impact and how they impact people, we know that a lot of these themes are probably relevant to broader populations as well. Okay, so when it comes to recovery from an eating disorder, it is possible even if a person has been dealing with their eating disorder for a really long time. And recovery is going to look different for everyone, but usually it includes developing more regular, attuned, and intuitive eating patterns, developing a more positive or neutral body image, and developing alternative and healthier coping strategies. So I have listed here some of the components that make up the most effective treatment for an eating disorder. So this includes psychotherapy. I don't really have time to get into all the acronyms, but I will say that cognitive behavioral therapy specific to eating disorders tends to be the first line treatment for bulimia and binge eating disorder. It is contraindicated for anorexia because along with anorexia is often malnutrition, which can lead to cognitive dysfunction. And so it's hard to engage in cognitive behavioral therapy when the brain isn't working how it should. Dialectical behavior therapy also is showing a lot of promise for bulimia and binge eating. And motivational interviewing and acceptance and commitment therapy have less research backing them, but do show promise for addressing ambivalence and body image distress. Support groups are often helpful, as we provide at Sheena's Place. Nutrition counseling as well. However, it's very important that that is eating disorder and health at every size informed. I can provide more information as to what that means at the end. But if someone seeks nutrition counseling from a dietitian or nutritionist who is not eating disorder or health at every size informed, it can have harmful impacts on the person and their eating disorder. And lastly, psychiatric medication. This medication does not directly impact a person's eating disorder. Like there's no medication that will treat an eating disorder. However, as I mentioned earlier, often people are dealing with concurrent mental health challenges. And so often medication can help with those. So depression, anxiety, ADHD, and then that in turn can help with eating disorder symptoms. Okay, and lastly, providing support. So I'm going to go over some best practices, of course, with the understanding of, again, that everyone is different. Depending on if you are a person providing support to someone else or to yourself, I think most of these are applicable. So number one, showing patience, compassion, and empathy. When you approach someone for the first time who you think may have an eating disorder, don't be surprised if they react with denial or anger. There can be a lot of shame that goes into having an eating disorder, as well as fear and anxiety. And so validating a person's emotions is really important, especially for folks who've experienced childhood sexual abuse. Feelings of shame and disgust with oneself may be particularly high. And so a person must be supported with compassion and non-judgment and acceptance, or we risk furthering that person's feelings of shame, embarrassment, or guilt. Seeking to understand what's going on and remaining non-judgmental is also very important. So as I mentioned earlier, not making assumptions about a person based on their body type or their identity, and asking questions in a non-judgmental and open way. If you're a healthcare provider, being cautious about prescribing or suggesting exercise as a coping strategy without gaining more information about what a person is going through, and focusing, again, back to the emotions, the most important part. Providing encouragement and emphasizing strengths. So encouraging, the person to see themselves as more than their eating disorder, and encouraging them to seek support when they're ready. And understanding that, this person is doing the best that they can in the moment, and that eating disorder symptoms reflect a way to cope with what's going on. What else? Reflecting on our own beliefs and biases about food and bodies is really important. So we are all inundated with messages on sometimes a daily basis that certain bodies, specifically thin bodies, are healthier than fat or larger bodies. But we need to unlearn this idea and adopt a health at every size belief system. Again, I'll provide more resources about that at the end. This, of course, takes a lot of time. It's really difficult, but it is really important. Along with that, critically analyzing social media and paying attention to who we're following is always a good strategy as well. Noticing how we talk about ourselves and others is really important. So I always suggest just avoiding commenting on people's physical appearance or food choices. That includes our own food choices and appearance and that of other people. We never know what someone is going through and how they're going to interpret something that we say. And so I think it's always best to focus more on complimenting people's personalities, things that are not related to what they look like, things like weight loss. It becomes risky territory, and it can be really triggering, again, especially for survivors of abuse, when, like I said earlier, certain weights may reflect experiences of abuse. Communication and setting boundaries, of course, is important. Establishing specific times to discuss a person's challenges or eating disorders. I usually recommend not doing so during a meal. So a place and a time that's more neutral and less emotionally charged. And when speaking, using I statements and avoiding like guilt tripping or blaming language. And lastly, acknowledging and validating our own feelings and engaging in self-care. We all, again, have our own relationships with food and our bodies. And so if you are a healthcare provider, this might not be something that you're comfortable tackling with your client or patient. And so referring out when necessary is really important, and not ignoring or avoiding those discussions altogether. Okay. So lastly, just a short FAQ about our programs at Sheena's Place. As I said, all of our groups are online right now. We use Zoom for healthcare, and most of our groups run on a seasonal basis. They're 10 to 12 weeks long. Sharing is not mandatory. People are welcome to join our groups and to do a lot of listening and to participate at their own pace and comfort level. We do have language guidelines that are reinforced by our group facilitators in a collaborative way. Our facilitators are all registered mental health professionals. And what else? You see the group numbers there. So we tend to register about 12 to 16 people per group. And to register, you can do so online. Our registration for our next 2 seasons, December and winter 2021, have just opened. A lot of our groups are full, but I'm happy to chat with anyone later on who is interested in what is available. Lastly, I do have resources here, but again, I will send these to Maria, and hopefully they can be disseminated to everyone. so that you have access to this stuff afterwards. So I won't spend time going through it all now, but I will say that NEDIC, the National Eating Disorder Information Center, is a really great resource to learn about what's available across Canada. And I have some more reading here in case you're interested in learning more about anything that I just spoke about. All right, again, I apologize for going so quickly. That felt like a bit of a whirlwind, but I'm happy to take the next few minutes answering any questions that anyone has.
Beautiful. Kaitlyn, if you could kindly stop sharing your screen. There was a question in the chat, and I think it's related to what we're all going through in terms of the pandemic. Someone mentioned that their partner has potentially developed anorexia as a result of COVID. They had been ill. And can you provide some helpful tips on how to deal with this form of anorexia from the recovery of COVID? So if this person's eating a specific food, their partner might be feeling repulsed by it, and they don't feel comfortable themselves eating around them, sounds like.
Yeah, first of all, thank you for sharing that. I know it can be so hard. We're in a pandemic, and when we're not living in a pandemic, this stuff is already so hard to deal with. So this, of course, is exacerbating challenges for everyone, whether that's someone having their own eating disorder challenges or someone supporting someone else. I think focusing again on emotions is really important. I know it can feel like the easiest thing to do is to comment on what a person is or isn't eating, but ultimately that's usually not the most effective approach. And it can be really hard to not talk about that stuff, especially if it's really concerning to us. But as caregivers or loved ones, asking the person like how they're doing, how can I support you? Those types of things tend to be the most helpful. And then if you are really concerned about a person's health status as a result of their eating disorder, connecting them to a healthcare provider is really important. So a doctor, a therapist, if that's accessible to you. Knowing that not all doctors and healthcare professionals are knowledgeable about eating disorders, but at least finding someone who's open to learning. In my opinion, it is, doctors and other healthcare practitioners' job to at least be open to learning about this stuff if they don't already know about it. And so I will, in the resource list that I will send, there is a link to NEDIC's website, and they have resources for caregivers and loved ones there. So like best practices, strategies, and as a caregiver or loved one, you're also welcome to call them for information about that, and they are there to help you. And one last thing, we at Sheena's Place provide a family, friends, and partners support group. And so that's something that's available as well.
That's great. Thank you so much for sharing, Kaitlyn. One of the thoughts that came up for me in working with survivors of sexual abuse and who have disordered eating was the notion of punishment and control. That really spoke to me because I hear that a lot in the sharing from survivors. And I'm wondering if you could shed some light, or what are some of the core beliefs that you've heard in your own group processes in general, obviously without sharing any confidential information. What are some of the common core beliefs that persons with eating disorders might be experiencing?
Yeah, that's a really good question. Things that I have heard include feelings of not feeling deserving or worthy of nourishing the body. So that could look like restriction because someone doesn't feel like they're worthy of food and of eating. So that's one form of kind of punishment or self-harm. Like the whole cycle of binging and purging can be really complicated around that as well. So this idea that there's so much shame often that goes along with engaging in binge eating. And then this idea that a person would have to maybe punish themselves for doing that through purging. In our groups, we because of our language guidelines, we don't go into detail about symptoms or trauma experiences. So I can't speak to specifics, but in general, those themes do come up without people naming them as explicitly. And yeah, I think a lot of it goes back to this sense of feeling deserving or worthy. A lot of people can have so much empathy and compassion for other people in their lives, and it can be really hard to turn that on oneself, especially after, maybe growing up in a really invalidating environment or in an abusive situation. Those things can be really, really hard to internalize.
Thank you so much for sharing, Kaitlyn. There was one other point that really stuck out for me because I'm working with a couple of people who have this experience. And it was where you mentioned the book Hunger by Roxane Gay, I believe you mentioned the author's name. So it's either weight loss or weight gain, some sort of relationship with at the time of the abuse. That's an interesting perspective to have, because a lot of survivors that I've met also shared that sentiment that they gained a lot of weight and keep the excess weight so that people would not go abuse them or go near them. They wouldn't find them attractive. So interesting that, yeah, I'm going to definitely take a look at that book. Thank you.
I'm not sure I can't remember if she speaks specifically about the weight loss or gain being triggering, but I know she does speak a lot about this relationship between like binge eating in order to kind of gain excess weight for exactly the reason you mentioned. And it's very powerful. Trigger warning as well. It's quite detailed, but it's a very, very well-written book.
Thank you so much. Just wanted to open up to the floor. Any attendees who would like to ask any questions of Kaitlyn before we wrap up in the next few minutes? Just keep an eye on the chat, and I'm just going to check social media to see if there are any questions there. Don't see any on social media, so any of the attendees listening in? Okay. Are there any services for people under the age of 17?
That's a really good question. So the availability of community resources is slim. There are a few organizations that I've listed in the resource list that have some online support groups for teenagers. We are not one of those organizations, but I believe Silver Linings, based in Alberta, and what else? The Eating Disorders Foundation, based in Denver, provide groups, support free or low cost support groups for adolescents. Typically for someone who is not yet 17, the first line response is to get them to a hospital program, because of course eating disorders can be really harmful to anyone of any age, but especially when a person is growing and developing, hospital-based treatment is the first line approach. The one in Denver is called the Eating Disorders Foundation. And yes, Maria will send a copy of these resources, and they're all hyperlinked. So you should be able to just click through and visit each website.
Okay. Well, thank you, everyone. And thank you so much, Kaitlyn, for spending time with us. Again, this video is going to be available. It's live on our social media channels, our Facebook and YouTube pages, and through our Twitter account as well. And I will be sending Kaitlyn a copy of the video. Thank you again, Kaitlyn. Thank you, everyone, for being here today. We wish you a wonderful rest and safe day to everyone who attended and everyone who's watching out there. And there's a message there for you, Kaitlyn. Thank you. Appreciate your dedication. It's amazing.
Thank you so much. I really appreciate the opportunity to speak about this, and I am happy to connect with anyone. You can just look up Sheena's Place, and I'm on the website. So please reach out if you have any questions at all.